Well, good afternoon, ladies and gentlemen, from a very windy Cape Town. It's wonderful outside, not a cloud in the sky, warm and windy. It's great to have so many hundreds of people logged on to this Zoom webinar. And my name is Peter de Jong. I'm joined by Professor Steve Jeffrey, the head of the Department of the Pelvic Floor Foundation. It's wonderful to have you here, Steve. And also wonderful, ladies and gentlemen, to have Dr. Femi Olarogun. As you know, he heads up the Heart Clinic and is also a visiting consultant at the Department of Gynecology of the University of Cape Town at Groote Schuur Hospital. It gives me great pleasure to invite Abbott, who are our sponsors. It's wonderful to have Abbott, and we're going to be hearing from Femi Olarogun in a minute about the use of dydrogesterone through the reproductive ages. We had a talk by Lo Pistorius on a similar topic through reproductive ages of fertility and pregnancy. We're not going obstetrics this time. We're sticking to gynecology. So without further waste of time, I'd like to welcome our two colleagues from Abbott and invite Chris, thank you very much indeed, Chris, for being with us, invite Chris to play the video from Abbott and kick off. Would you like to say a few words then, Steve?
Absolutely. It's wonderful to have Femi. I mean, I met Femi all the years ago when he was still a registrar, and we went through our reg training together. So it's but I think what a wonderful topic. You know, I think we are seeing more and more discussion around this, and to have it sort of pulled together in the topic in the talk is going to really looking forward to it. So Femi, thanks so much, and yeah, thanks for taking time to join us this evening. Are we then moving on to the Abbott guys now, Pete?
Yes, we are, Steve. We're going to have the video, the indefatigable Abbott person, whose name is Devon, and his colleague. They're going to be playing the video of Abbott. Thank you, Steve. Let her roll.
Progesterone is a steroid comprising of 3 cyclohexane rings and 1 cyclopentane ring. It is manufactured for therapeutic use from the wild yam root Dioscorea species. Due to rapid first-pass liver metabolism, progesterone has variable concentrations and very low oral bioavailability. Therefore, it is administered via injection or vaginal route, which are not easy to use and associated with side effects. Dydrogesterone was introduced for clinical use under the trade name Dufeston in the 1960s for treatment of conditions associated with progesterone deficiency. The manufacturing process of dydrogesterone is highly complex. It starts with the chemical modification of progesterone, followed by a critical phase of transformation into dydrogesterone. This is done by passing it through UV light at an appropriate wavelength, intensity and time sequence, resulting in a unique, modified retrosteroid structure. This manufacturing process makes dydrogesterone the only commercially available retroprogesterone. The bent conformation of oral dydrogesterone enhances the rigidity of the molecule compared to progesterone. Due to its unique structure, dydrogesterone is highly selective for progesterone receptors, supplementing deficiency of endogenous progesterone. It has negligible interaction with other steroid receptors, resulting in a lack of androgenic, estrogenic, glucocorticoid and mineralocorticoid effects that can occur with other progestogens. Dufeston, containing 10 mg dydrogesterone in each tablet, is formulated to have good bioavailability, enabling convenient, patient-friendly oral administration. Improved oral bioavailability and the receptor agonist activity of its metabolites causes secretory transformation of the endometrium, progestational activity, at a dose 10 to 20 times lower than micronized progesterone. Various progestogens have been investigated to support endogenous progesterone in the treatment of luteal phase deficiency. Only Dufeston, progesterone and 17-alpha-hydroxyprogesterone caproate are currently approved for clinical use during pregnancy. In women undergoing assisted reproduction, Dufaston supplements endogenous progesterone and provides orally effective luteal phase support, contributing to successful and comparable pregnancy outcomes versus vaginal micronized progesterone. To date, around 113 million women throughout the world have experience with Dufaston, including 20 million fetuses exposed to dydrogesterone in utero.
Well, thank you very much indeed to the manufacturers and presenters and sponsors of Abbott. It's a wonderful, wonderful experience that we're going to have now, because we have Professor Femi Olarogun. Femi, there you are. Can you show share your slides, please?
Sure. 2 seconds. I got cut off because of that video. Is that on? Give me 2 seconds. Should be come back on now. Is that on?
Here we go. I can see you loud and clear.
Okay. Thanks very much for inviting me to the Pelvic Floor Foundation. Steve and Professor DeYoung, I appreciate this.
Professor DeYoung.
Yes, for the next sort of 40 minutes, 30 minutes, I'm going to try and talk through dydrogesterone through the reproductive ages. What I thought it would do is go through what it is, and then we'll talk about, why it's special, which that video has probably addressed already, and then its applications, and perhaps if there are any risks involved with using it. I'll let you look at that slide for about 30 seconds. It's just a disclaimer that Abbott is indeed sponsoring this particular presentation. You agree what they say. What they're saying is that I'm on my own, basically, if anything comes out of this. So that's what it comes down to.
Okay.
Yeah.
Right. If you talk nonsense, it's not their problem.
Exactly.
Femi, would you mind us interrupting you if we have some of the delegates who have questions as you go along? Would that be a problem? Okay.
I think it's much better to sort of do that, and then we can interact that way. All right. So like I said, we'll talk a bit about what the molecule exactly is. We'll talk about why it's different, where do we get it applied, what are the concerns, and then maybe a few conclusions. So dydrogesterone is a synthetic orally active progestogen, specifically a 6-dehydroerythroprogesterone, which you've heard about in that video a couple of minutes ago. It was developed in the 1950s and was introduced into clinical practice in 1961. Structurally, it's similar to progesterone, but with better enhanced bioavailability than progesterone. And if you look for what the classification for progesterone is, you will find like there's so many of them. Sometimes classified into first, second, third, and fourth generation, depending on how much their androgen activity is. Also classified in various other ways. But I found this was probably one way that made it kind of look probably easier to understand. So you look at progesterone, it could either be natural or synthetic. The natural progesterone we know. The synthetic one could be structurally related to progesterone or could be structurally related to testosterone. The one related to progesterone, you can then divide into the retroprogesterone, where dydrogesterone falls into, or the 17-alpha-hydroxyprogesterone derivatives, which is your MPA, which we obviously use clinically, sapropterin acetate, which, as you know, we use quite often as well, especially in patients with cysts and PCOS. And then the 19-norprogesterone derivatives, example, normogestrel acetate and promegestone. And then there are those structurally related to testosterone, the 19-nortestosterone derivatives, and those are either esteranes, example, norethindrone acetate or norethindrone. And then the gonins, which are levonorgestrel, which obviously we're quite sort of familiar with as well, desogestrel, gestodine. And then the last one is the ones that are structurally related to spironolactone. And that will be your drospirenone, which is also available, as a formulation as well. Again, this is just similar sort of breakdown, but maybe in a more, sort of schematic sort of diagram and a bit more detail. So you got your progestins, and then the one structure related to progesterone on the left of the screen can be divided into pregnins with the methyl group at carbon 10, or the non-pregnins, which has no methyl group at carbon 10. And then the pregnins can then be divided into the acetylated acetate group at carbon 17, and that's your MPA and the sapropterin acetate, and then the non-acetylated group, which is the dydrogesterone and metrogesterone. And then on the non-pregnant side, you have the acetylated group, which you then have, non-gestrol acetate, and then the non-acetylated group, which is those ones that you can see there. And then the ones that are structurally related to testosterone on the other side of the one that's probably a little bit important there is the no ethinyl group at carbon 17, which is your dydrogest, which obviously we're all familiar with, especially in patients with endometriosis. And then you go further onto the other side, and the levonorgestrel then comes in. So what are the properties of dydrogesterone? The first thing is that it's orally active, and that again is a big plus, and you see why I say that, because a lot of the other progesterones we have that we use clinically are not orally active for these indications that we're talking about. It's got high bioavailability, 80 to 90% being absorbed, compared to micronized progesterone, where only 10 to 20% is absorbed, and to your MPA, where 20 to 40% is absorbed, and norepinephrine, where there's about a 60 to 80% bioavailability. So it's pretty good in terms of being, bioavailable. It's got a long half-life of between 12 and 24 hours. It's got selective progestogenic activity, which then means that, it goes where you want it to go, with perhaps then, minimal, sort of external effects of progesterone, and then minimal androgenic and estrogenic effects. So those are the special properties that one could say that, dydrogesterone, possesses. So just to remind ourselves, the physiological actions of progesterone, we obviously all encounter this on a daily basis. Progesterone is produced by the corpus luteum, it's produced by the placenta, and also by the adrenal gland. And it works right around, as far as reproductive medicine is concerned, really everywhere. It's responsible, or it's in play when we're talking about priming the endometrium for embryo implantation. So we need that in IVF, and we'll talk a bit about that. It helps in regulating luteal phase and ovulation, menstrual cycle. Obviously, without progesterone, you have patients who then have, excessive estrogens, and then they bleed and ovulatory cycles. And then it maintains the quiescence when the patient is pregnant. So in other words, we all know that when the effect of progesterone is to keep the uterus, nice and not go into labor or not contract until you want it to actually do so. And then once progesterone activity is taken off, then the patient then starts contracting or goes into labor. And then as far as breast are concerned, you have lobular and alveolar development that also depends on progesterone, and then so lactation to follow. And then it's also a precursor for steroid hormones, aldosterone, cortisol, testosterone, estradiol. So it plays a very central role in human reproduction and in gynecology as a whole. So what applications are we going to talk about in terms of why dydrogesterone, will be useful and how we can use it? The one is menstrual disorders, endometriosis. I'll talk a bit about infertility, pregnancy support, that's assisted reproductive treatment, as well reproductive, sort of therapy. PMS, which, is often quite difficult to treat, and, anything that we can probably use for these patients is good. And then HRT as well. So talking about menstrual disorders, we all know about our patients with polycystic ovaries, and they have ovulatory cycles where they just get exposed to estrogen all the time, and there's no ovulation. So after a while, then they start, the endometrium tends to, then over-secrete, and then you have lack of protection of progesterone, and then what you then can have is a loss of cycle regularity. And dufaston, in a cyclical form, like you will probably use other forms of progesterone as well, for 10 days or 10 to 14 days every month, helps to maintain cycle regularity. Patients with dysmenorrhea could also benefit from the use of dydrogesterone at the dose of about 10 milligrams BD from about day 5 to day 25. Again, these patients obviously are put on non-steroidals, some of them put on just normal contraceptive pills, but this is also an option, for patients who have severe dysmenorrhea and so on, we can sometimes consider. And then patients with long and heavy periods around what I've just described, similar doses to above have been shown to be quite effective in those patients for those menstrual problems. And then patients with continuous bleeding with the predominance of estrogen may benefit from duphaston given for maybe about 3 weeks, and then going back to the cyclical thing. So you're basically trying to thin the endometrium out, and then going back to cyclical to try and get that, that under control. So it plays a role in terms of trying to, take care of menstrual problems that, patients might have. What about endometriosis? So dydrogesterone is just recently licensed for the treatment of endometriosis in South Africa at a dose of about 20 to 30 milligrams daily from day 5 to day 25. Has been shown to be effective in pain control while still allowing pregnancy to happen. And I'll talk a little bit more about that in a minute. If you give the same dose continuously, just 20 to 30 milligrams a day in patients who do not want to get pregnant, then you will achieve good pain control as well. So what I'm trying to say is that in patients who are hoping to conceive, as you know, when we have patients with endometriosis, you're either treating pain or you're treating fertility. You're doing one or the other. It's very difficult to actually treat both because everything we give to try and control the pain will prevent them from getting pregnant. But this offers a little bit of a loophole in terms of if you use it cyclically like this, you might actually not suppress ovulation, which is one of the things that duphaston doesn't do. And you could potentially get pregnant, while you're still trying to get pain control. So what is the mechanism of action in endometriosis? It inhibits estrogen-dependent growth and subsequent symptoms from there, causes basidialization and subsequent atrophy of the lesions, also has an anti-inflammatory effect, with reduced angiogenesis, and modulates the whole environment, the whole hormonal environment to a less estrogen-dominant one, and therefore perhaps making endometriosis less of a problem that way. It's probably important to compare it with where most of us will go nowadays that deal with endometriosis often, which is Dydrogest. And if you look there at that table, the efficacy of Dydrogest for endometriosis is considered higher when it comes to treating endometriosis pain. Dydrogesterone is effective but lower than Dydrogest in terms of the effectivity of the molecule. It does not suppress ovulation, whereas ovulation is completely suspended in patients who have who are on Dydrogest 2 milligrams a day. Primary use treatment of endometriosis, but dydrogesterone might then come in those group of patients, like I mentioned, who might, who wouldn't mind conceiving but still have endometriosis pain. Might be something to then consider. And then patients do complain about Dydrogest, about abnormal uterine bleeding, especially at the beginning. Obviously, most of them will have amenorrhea, which is not necessarily a bad thing. But dydrogesterone will give you generally fewer side effects. So just to give you an idea, where you might place. I'm not saying that Dydrogest it should be replaced by dydrogesterone, but what I'm saying is that it's just another thing that we have in an armamentarium in terms of treating endometriosis, where these patients who probably not doing well on other options that you've given them, you got something else that you can use that could potentially help, with pain. What about infertility? So we know that, dydrogesterone is used for luteal phase deficiency and pregnancy losses because uterine receptivity and implantation improves. And the Lotus 1 and 2 trials suggest that it's as effective as vaginal progesterone in luteal phase support. So just, make this a bit clear. So there are a lot of patients who have luteal phase deficiency tend to have perhaps very early pregnancy losses. Some of them you pick up clinically, some of them you probably don't, and they just present as infertility. So these patients have a deficiency in the progesterone levels that keep the pregnancy going, so much so that then what then happens is that they lose a pregnancy because there's no support for the pregnancy. So the typical thing to do in this kind of patients, when obviously luteal phase deficiency is quite difficult to diagnose, you should actually be doing sort of endometrial biopsies at certain times of the cycle to try and make a proper diagnosis of it, which most people don't do. But if you have patients who are losing pregnancies quite early on, and you suspect that they might have, sort of luteal phase deficiency, and so this is actually very, very useful. So what we do with these patients is start them on 10 to 20 milligrams of dydrogesterone from about day 11, day 14, or day 15 of their cycle. And I just say, just continue taking that until, the next period is due. And if you don't get a period with pregnancy test, and if it's negative, then you stop. But if the pregnancy test is positive, then you can just then continue to go on with your dydrogesterone. And, you can then continue for up to about 12 weeks, sometimes even up to about 20 weeks. And that's the recommended time, especially patients who've had recurrent, pregnancy losses. And you could do that for a few cycles in this patient to see if that is what the problem is. So that's what the duration is about there. So just in a nutshell, luteal phase deficiency, patients' early pregnancy losses, if you start in the luteal phase, progesterone, before the pregnancy actually happens, and then you expect that when they get pregnant, you can then just keep going with it. What about pregnancy support? So
Can I just interrupt you, Femi? Can I just interrupt you? Pamela Naidu wants to just ask how much and when can it be used to delay menstruation?
It's the same way you would use any progesterone, really. So if you catch them early enough, I would say, if we put them on progesterone or dydrogesterone right through the cycle, I would say from about just as the cycle ends and you keep going, that should delay their periods. So it's right from when the period ends and you keep going with that, should keep the periods away. Okay. Does that make sense? Yeah.
Yeah. And then another question from an anonymous attendee: is there any way to diagnose luteal phase deficiency?
So that's the thing. I mean, it's a difficult diagnosis to make. So the way, the way the textbooks describe it is that you should actually be doing, biopsies of the endometrium serially to actually demonstrate that there's sort of luteal phase deficiency. But the way I would go about it, the way I do it clinically is basically you see patients who, when you see them have, by the time they're 5 weeks or 6 weeks pregnant, you do a scan, there's a sac, there's no pole. So very early pregnancy losses, and it's recurrent. And that, so whatever the reason is for them losing the pregnancy starts very, very early. And in those group of patients, you got to suspect that they have luteal phase deficiency.
Okay, thanks.
Yeah, all good. So talking about pregnancy support, so traditionally what we use in IVF has been either vaginal or parenteral progesterone, and this has been used for decades to try and, from the, again, luteal phase of the IVF cycle, so immediately the egg retrieval is done, you start progesterone supplement, and that has been shown, by numerous studies, including, Cochrane data reviews and all that you do need to do that to increase your pregnancy rates. Oral administration, however, offers a more patient-friendly route for this indication. It's less messy and less painful. The parenteral progesterones are particularly painful, and patients often complain about the vaginal preparations we have, as far as progesterone is concerned, as being quite messy. And there is ample evidence that dydrogesterone in divided doses, usually 10 milligrams TDS, so 30 milligrams a day, is as effective as traditionally used progesterones for this indication. So again, some evidence for oral dydrogesterone. I'm not going to go through that study, but basically what it's saying is that in the luteal phase support in patients with IVF and ICSI cycles, that your dydrogesterone is not inferior to micronized progesterone like we use it. So your vaginal micronized progesterone was the comparison here, and there were no significant changes when you compared it to oral dydrogesterone in this group of cycles. It was a small number of people. If you look at the Cochrane review, and I will just take you down to the lower part of that. 2 points there: neither the addition of estrogen, which some of us do, nor the route of progesterone administration appears to be associated with an improvement in outcomes when it comes to, live birth and ongoing pregnancy. But, use of progesterone is obviously indicated, but whether you use it vaginally or orally, it appears that there is actually not much, evidence to suggest that it's inferior. Yep.
So I finished that antibiotic that Dr. Fritz gave me.
Oh, that wasn't for us, was it now? Hello.
I don't think so, Femi.
Sorry
Okay,
about that.
Please
Just,
continue.
on
There
a,
was a-
sorry, guys.
Okay, no hassle at all good. So are there comparative studies for micronized progesterone versus dydrogesterone? There's a few of those, and if you look through that, basically the feeling and the conclusion is that similar pregnancy and live birth rates. Dydrogesterone may have fewer side effects and better patient compliance, which, from what I've said earlier, makes sense. Micronized progesterone may have more localized effects on the endometrium, but again, it doesn't translate into like better pregnancy rates or take-home baby rates. I need to mention here that there's an off-label use of dydrogesterone that a lot of clinics then use around the world at the moment. Traditionally, when you're doing a short protocol IVF cycle, we use a GnRH antagonist in the form of cetrotide, which is a parenteral application, which is a daily application, to try and prevent premature luteinization, normally starting from about day 8 or day 9 of your stimulation. But nowadays, with dydrogesterone, it has been shown that if you use 10 milligrams, between 10 and 20 milligrams, starting right at the time that you start your stimulation protocol, you actually prevent premature luteinization of the follicles until you want to trigger and retrieve them. Now, you could argue that this kind of flies in the face of what I said earlier in terms of it not inhibiting ovulation. But this particular action is thought to be an effect on the LH receptors directly, and rather than suppress it, actually modifies it. So that's, obviously being investigated, we do need to, get more evidence, but we do know it works. So in a number of clinics, that's what we do. It's obviously cheaper than giving cetrotide, which is the other option, and it's easier to use for the patients as well. So it's an off-label use, but it's something that we do use. So what about threatened miscarriages? I mean, there's so much that, you could read about. And for years, we've talked about using progesterone in patients with a bit of a bleed, and does it make a difference? Numerous trials, as you all know, has gone before that to try and answer that particular question. But in line of, this is what I picked up, when eventually looking at this, it actually came from the Turkish guidelines. This is Turkish guidelines on threatened miscarriages and recurrent miscarriages, which was just published this year. And what they're saying is that, having reviewed all the evidence, oral dydrogesterone treatment may be considered as first choice in threatened abortion, since it has fewer side effects and is found to be more effective in most studies compared to micronized progesterone. So NP, again, you have to give vaginally when the patient comes in with a bleed, and especially patients who've had previous miscarriages before, you'll probably get probably get a better effect when you give dydrogesterone, because it's an oral, oral bioavailable, sort of molecule. Micronized progesterone given vaginally could then be washed away, with the bleeding that the patient does have. So it's always a bit of a concern. So when you look at recurrent pregnancy losses, there's evidence suggesting that dydrogesterone may be effective in reducing the risk of pregnancy loss in women with a history of recurrent pregnancy loss. And these are just a bit of what we know about in the 2015 study published in the Journal of Clinical Endocrinology and Metabolism, found that dydrogesterone significantly reduced the risk of miscarriage in women with recurrent pregnancy loss. In the 2018 systematic review, a meta-analysis also published in Journal of Clinical Medicine, dydrogesterone was effective in preventing miscarriage in women with a history of recurrent pregnancy loss. And then the Lotus 1 and Lotus 2, again, tells us that dydrogesterone is effective in supporting pregnancy, but this was more related to IVF. So that's recurrent pregnancy loss, and it might be something to then consider. What about premenstrual syndrome? Well, this is a condition that obviously affects a lot of women. It's something that often gets brushed aside, I suppose, by clinicians, because we often don't know what to do with it. You put them on a pill, they don't do well with the pill. You put them on sort of supplements, and there's still always an issue. But there's evidence suggesting that dydrogesterone may be effective in managing premenstrual syndrome. So the idea is to start in the luteal phase. So for instance, a 2008 study published in the Journal of Psychometric Research found 10 milligrams daily of dydrogesterone reduced PMS symptoms, including mood swings, anxiety, and physical complaints. And the 2013 Cochrane review suggests progesterones, including dydrogesterone, may be effective in reducing PMS symptoms, but noted the need for more rigorous trials. It was in 2013. And then in 2019, systematic review in Journal of Regen's Clinical Psychopharmacology found dydrogesterone effective in alleviating PMS symptoms, particularly in the luteal phase. And the possible ways it might do this is regulation of hormonal fluctuations, reduction of estrogen-progesterone imbalance, as an anxiolytic and an antidepressant, and also dosage of about 10 to 20 milligrams starting from about, the luteal phase, sort of days 14 to 28, is what you want to do if you're trying to use this as an option. Again, it's not the be-all, end-all of managing PMS, like I was saying about endometriosis. It's just another tool that we have that that one could think about when you're managing some of these quite difficult conditions. What about hormone replacement therapy? We know, that if you have a uterus, you do need to protect that uterus with some progesterone. That could either be given transdermally, orally, or via an IUCD in the form of a Mirena. The side effect profiles vary depending on the type of progesterone and the route of administration that you're using. And the first thing just offers you that it's available commercially in the form of famotidine 110 and famotidine conti. So in a continuous, in patients who've been, sort of menopausal for over 12 months, and you want to give them a bleed-free treatment, you can give them the conti, which is then, keeps them from bleeding. And in patients who are still perimenopausal, who still produces some endogenous estrogens, you probably then want to give those patients the cyclical one. It's effective in terms of endometrial protection. It's got a favorable bleeding profile, minimal metabolic impact, some evidence suggesting some cardiovascular benefits, more studies needed in that, and available in a continuous combined or sequential preparation, like I've mentioned. So are there side effects or concerns to the use of duphaston? Like all hormonal preparations, patients would have side effects, issues like nausea, headaches, breast tenderness, mood changes have been reported. Less commonly, weight gain, clotting disorders, and liver enzyme changes, and then very rarely thromboembolic events and liver dysfunction. But when you put this against the other progesterones that we have, it's actually quite well tolerated, by patients, and with very minimal. A lot of the side effects are pretty rare, so consider quite safe, when you're, using this product. So in conclusion, dydrogesterone is a versatile progestogen. Its rapid absorption, high bioavailability, and long half-life makes it pharmacologically attractive and, it's for us to use. It also possesses selective progestogenic activity, making it a good choice for various reproductive health indications. And the oral route of administration and favorable side effect profile make it an important addition to our armamentarium of things that we have in managing these gynecological conditions. Thank you very much.
Thank you very much indeed, Femi. And I'm going to ask Steve to thank you. Steve, are there any questions? I have one or two over here.
Yeah.
Pete, there is one question again by an anonymous attendee. Is dydrogesterone recommended for a patient with threatening miscarriage without a previous history of miscarriage?
So the evidence for that is tenuous. But yes, the fact is that, what else do we have? We have, for years, we've talked about bed rest, which does absolutely nothing. I think most of us would actually put those patients on progesterone, if they come in and they have a bleed, especially early on in pregnancy. So I would say yes. It's value recommendation as far as threatening miscarriage is concerned.
Absolutely, I'd agree with that. Very difficult if a woman comes in with bleeding early in pregnancy, just to say go to bed, because some form of progesterone would seem to be entirely appropriate in this case. Another question over here, Femi. You mentioned in your previous slide that there's very rarely effective thromboembolic phenomenon. How do you explain thromboembolic phenomenon in a progesterone use?
It's, I actually thought about that often. Obviously, we know that estrogen is the main culprit there. But if you look at the labels for most progesterone preparations that we have, thromboembolic disease is mentioned as a potential possibility. And I think it's probably because they're trying to cover themselves to a large extent, just so that that it can happen. I mean, we know it's a
Yeah.
precursor of many, sort of hormones. So, you're given a hormone that could potentially be converted to other kinds of hormones in the body. And you could, from that point of view, then say perhaps it increases it. But I think the risk is actually quite slim.
I would have thought so. It sounds a bit like a disclaimer to me, rather than an actual physical, clinical entity. Steve, there's another question there.
Yeah, it's from Cadenopolis, in a transitioning patient who is currently taking testosterone to transition to male, now with chronic pelvic pain, with a Colleen device and no periods. Pain is likely due to endometriosis, multiple hospital admissions for pain. Would adding dufaston 20 milligrams a day help with the pain and not combat the testosterone effects, thus slowing their journey to transition to male? Quite complicated.
Kelly has some very exciting patients, I see. So
you can see. Yeah.
I think the bottom line is, with this, I mean, if she's thinking it's related to endometriosis, with endo, you basically have to go with the textbook. So, I've got patients who got a Mirena in, who are on, sort of tripling, 10 milligrams at night. We're on Visan as well, sometimes not Visan or Clyra. So often there's a need for combination therapy in these patients because obviously their pain is often, just not responding to one agent. And sometimes the pain is not just about the pelvic pain, it's a pain that, there's a psychological component to it as well. So you want to throw in as much as you can, really. So I would say, depending on what the patient is on, I would definitely consider using, this as one of the options that we have to try and get the pain under control. Not necessarily on its own, but maybe as a combination with something else in that kind of patient.
Femi, can I just ask as a question?
Yes.
If a woman is transitioning to a male and she's taking testosterone, what effect will the now, assuming the patient's had previous endometriosis, what effect will the testosterone have on endometriosis, if any?
Question. Probably should make it better.
Theoretically, it should, shouldn't it?
Yeah.
Do you have any, or Steve, do you have any experience with women transitioning and having the testosterone applied? Femi? Or Steve?
I don't have any experience. I don't, but this gentleman certainly. I mean, I think I doubt the progesterone will make a difference to the transitioning and to the desired physiological effects in this person. So yeah, I mean, I think it would be quite supported and would suppress the endometriosis. So I think it would be fine. That's from a very basic knowledge. But I mean, Femi, what are your comments here?
No, completely. I think so too. Like I said, I mean, endometriosis, sometimes you have patients that you're thinking, you've seen them over so many years, and you begin to think, what else can you actually do to keep them, sort of comfortable, because they just keep coming back, whatever you do. So like I said, this is just something else that you have that we can actually throw in. And I've got a few patients that I've put on dydrogesterone and I've, at least, tided them over for a little bit. So I wouldn't hesitate doing that. But to answer your question, Pete, I don't think testosterone causes a flare or anything in endometriosis. If anything, it might actually help, keep it at bay, if anything.
Yeah.
But I don't have a lot of patients on high dose testosterone. I don't have a lot of patients that I'm treated for whatever indication with that.
My only experience with these patients has been to, offer them surgical support, and I think this might be a good time to even start considering hysterectomy and definitive surgery there, because I think ultimately you will need a hysterectomy. So yeah, getting minimally invasive hysterectomy in this person might be a good option early on in the transitioning phase if they can get that covered.
Yeah.
The next question is from again anonymous attendee: can we use it for prevention of preterm labor, and if so, at what dosage? It seems to be comparable to micronized progesterone.
That's a good question for you, Femi.
It is a good question. So I mean, that wasn't actually part of what we talked about in this thing, but I mean, I would use it pretty much the same way you use micronized progesterone as far as preterm labor is concerned. And in the studies that I've seen, and Kamani might be able to come in here, so she's still online, you probably give a start dose of like a 40 milligram. And then something like 30 milligrams a day in divided doses would be something you will probably consider for that indication. Kamani, can you come in? Is that a registered indication for dydrogesterone in South Africa?
So, Dr. Olarogun, it's preterm birth is not one of the registered indications for dydrogesterone.
Yeah, I don't think so. So it's not something that has been registered as an indication for use of dydrogesterone in South Africa. So we should probably use what we have that is registered.
Okay, so it would be off-label use.
Yeah.
Here's another one from Kaylin. I'd love to do a hysterectomy, but the patient is only 18 years of age. This is, I guess, referring to the person transitioning to a male, and that Steve said he'd do a hysterectomy on. Comment, please, Femi.
Yeah, I mean, it's always difficult coming without seeing the patient. I mean, 18 is probably quite early in terms of the transition phase. I mean, there's various literature around there suggesting that what's the best age to try and the transition for a male to female or vice versa. Bearing in mind that a lot of what we do is quite permanent, to these patients, and you got to be absolutely certain. And I'm sure Kaylin has done that this is exactly what the person wants. So, in other words, psychological involvement. Lots of sessions with various sort of doctors before you can actually make that call. But I mean, I'll be reluctant to do a hysterectomy at that age, that's for sure.
Obviously, it does add some complexity because obviously there is a fertility option, even though the person is transitioning. So, I mean, in the end of the day, maybe that is something that we need to bear in mind too. So, thanks for a great question. We maybe shy away from discussing these things in these in these sort of discussions, but there are patients that we see, and good luck with the management of him. And thanks for opening up the discussion. Yeah. The next question from Yonela and
Stephen, I wonder if I can ask on this very.
Sorry,
Steve,
Karen,
can I just ask Femi? If a person is transitioning from a female to a male under these circumstances, what family planning contraception would you use, Femi, to avoid unplanned conception?
So I mean, they actually, the ones I've seen just stay on the pill, really. I mean, perhaps it depends on what stage they are in their transitioning program, right? I mean, one of the things you could probably consider is putting Mirena in while she's still got a uterus, right? Put the Mirena in, then you buy yourself 5 years while you're giving her sort of your testosterone supplements and things. So it's got to be something that I suppose doesn't mess with the systemic hormones, that you're playing around with already. So I mean, I would probably consider something like a Mirena or perhaps even a normal IUCD, but a Mirena obviously helps with periods as well.
Yeah. Because I'll tell you why I asked that question. It sounds like an esoteric question, but I had a case of a woman that fell pregnant in the middle of her transition, and this person opted for a termination. But you can imagine that the emotional shock and consternation was more than considerable in a person transitioning from female to male and then conceiving. Okay, thank you. There's another question. Steve, you were going to say?
It's from Yonela Nkonzo. So what is the evidence for the use of vaginal progesterone on twins with a short cervix prior to 28 weeks and with threatened preterm labor?
That's another good question for Femi to get his teeth into.
It's a great question. This is coming from someone who hasn't done obstetrics in like 10 years. So I'm going to say to you that twins is a bit of a look, most of the studies were done in singletons. Whatever you're using to tokenize those patients in preterm labor. And it's almost like an extrapolation as far as I remember when you're talking about twins. So it's very difficult to make, sort of strong assumption that that's actually the case. But if I were faced with that kind of patient, I would definitely use progesterone in her. Because, I mean, again, you've got to weigh up the risk and the harm, and you're not doing anything in terms of doing too much harm. So I would definitely consider using progesterone for that specific indication, despite the fact that she's got twins. And that it might not be as effective as if it was a singleton.
Yeah. It would be off-label use.
Yeah.
Steve, can you just read that question? It seems to have disappeared off my screen. What about the cervix, did they say?
Short cervix twins with a
Twins,
Yeah,
short
yeah.
cervix,
I would have thought that it would be useful, but albeit off-label, but it would be entirely justifiable, I guess. Yeah. Steve?
Yeah. Yeah, I think that is all the questions, Pete. I mean, Femi, for someone on women on Femi gel, as an example, your choice for add back, is it an oral progesterone, or would you go for I mean, where do you go from there? I mean, what is your preferred starting point?
Good question. I mean, so I would often go for the patches as my first line, especially because you're bearing in mind the risk of thrombosis and all that as well that we spoke about earlier, especially patients who've got a uterus, you're giving estrogen and progesterone. I'll probably go down that route first. And I suppose the next line for me would be try and protect the uterus by putting, again, a Mirena in the uterus. And then you can play around with how you give her the estrogen, afterwards. So, I mean, those are like probably, and then it's just less complicated that way because the uterus is protected. So those are my two routes, so to say, that I would prefer. And then obviously oral, preparations are available. And if I was to use one of those, then this one we've just spoken about would be the one, again, purely from the side effect point of view and the fact that it's well tolerated.
Femi, can I just come in over there? I asked that same question. What is Devon? Are you still on the webinar, or your colleague? Is it permissible to use dydrogesterone with Femigel for menopausal therapy or not? Hello?
Is that for me or
for Devon?
Yeah.
Can I take this, Dr. De Jong? It's Carmen, the medical manager at Abbott.
I think your man's gone drinking. So tell me where you stand. Where does Abbott stand with dydrogesterone, as Steve calls it, an add back to the use of Femigel, which is estrogen transcutaneous cream, to prevent hyperstimulation of the endometrium in women with menopausal therapy? Yes or no?
Yes, so that is one of the approved indications in South Africa for the first.
Okay, so we may use it. In short, the answer is yes. What dose and what regimen? 10.
Yes, so according to the PI, the package insert, it's 10 milligrams.
Every day or in the second
Once
half
a
of the
day.
cycle? Daily. Okay. Well, that answers that, Steve. There you got your question from Kamani, short and to the point.
Thank you very much. One other question here, again from an anonymous attendee, about the sedative effects of dydrogesterone. Is it sedative like micronized oral progesterone? Does
Or
anyone
not?
In my research, I didn't come across that as a major side effect. And I've been using dydrogesterone for a long time, and really patients often don't complain about it the same way they will complain about heavy doses of progesterone. So that's another kind of slight advantage is, if you're using parenteral and perhaps some of the other progesterones that we have available, there is a lot of patients who complain of somnolence and tiredness. And I think you don't get that much. I mean, there will be some of it's a progesterone as well, but it seems to me as if it's not as much with dydrogesterone compared to the other ones.
Okay, that's wonderful. Steve?
Yeah. I don't know if any other questions, but I mean, thanks, Femi. It's a wonderful topic to have, embarked on, because, we do find it quite confusing, a lot of us, how we use, the oral progesterones, and, they've got so many indications, from pregnancy all the way through to the menopause, and, we often, and the evidence changes a lot. And so, but thanks for summarizing it so nicely for us. And I'd like to thank, everyone who attended for the great questions. And again, thanks to my colleague, Pete De Jong, for his indefatigable energy.
Indefatigable.
Keeps bringing to these webinars. And thanks to everyone for joining. And again,
Can I just have have a last question?
You can have the last question.
Yeah,
Yes.
like last week, we just carried on and on and on. Femi, You were recently in Istanbul, and did they mention dydrogesterone, or was it on a different topic?
Ooh, the last trip to Istanbul was on ESGE Congress, European Society of Gynecological Endoscopy. So it was more surgical than anything else. There was
Okay, it wasn't endometriosis.
No,
Okay, I thought endometriosis was part of the program. Okay,
No.
Femi. Well then, Steve, final word for Femi, and a final thank you to Abbott.
Yes, again, I've really thanks so much to Femi, and you know, we did appreciate it a lot. Thanks to Abbott for their input and for the sponsorship, and again, also thanks to Chris for you know, keeping the webinars going from an admin point of view and from a technical point of view. So yeah, that's it, and much appreciated. Anything else, Pete?
Yeah, final word. Jocelyn Helix with us next week. It's always wonderful to hear from Jocelyn. She's an endocrinologist. For those that haven't met her, she's been with us before, so she's always good value. And she next week we're going to be speaking about drugs for weight loss. So that's another great topic. All of us, well, some of us more than others, need a knowledge of this sort of thing. And if we don't need it, then the patients do. So, ladies and gentlemen, safe home. Femi, a great big thank you as always. Been wonderful having you here. The number of delegates logged on is an attestation to your popularity. Steve, thank you very much indeed. And session 5, we're now getting to the end, series 5, episode 38. So we're almost at the end. We finished at the end of this month, ladies and gentlemen. So from all of us over here in Cape Town, a great big thank you. Good night and Godspeed.
Nice.